I'm Dr. Theresa Chiang. My specialty is in pediatric dentistry and epidemiology. So topic of my talk is importance of dentistry role in the management of cleft, lip, and palate. The reason I'm putting Boston and Harvard University there is because we have a program in China. We started in 1999, and we have exchange visitors from North America, from US and Canada, especially Harvard. So we did a lot of exchange programs between China and Canada, and we have crowded the very first center, followed by a children's university for very high. You can see prevalence varies quite a bit among different countries and ethnic groups. Just in North America alone, you can see there's quite a difference. It's relatively high among the Japanese and Native Indian, and the white is 1 in 800, followed by the Afro-American. They're relatively low, 1 in 2,000. And in China, it's quite high, 1.282%. And you can see cleft lip and palate prevalence is extremely high among the total congenital anomalies, ranking 2nd to 3rd. We have a lot of challenges in the management of cleft lip and palate because it's a lot of tissue movement. So we have to worry about actually the whole different involved. You can see because we involve multiple surgical procedures and there's differences in appearance at different stages of life. Then we have to worry about behavior disturbances. And as far as the dental treatment is concerned, it's quite free and very costly, and also associated hearing loss and about genetics with children. I'm going to skip the other one. So basically, these are, in North America, we have literally cleft team approach as far as management of cleft children are concerned. Plastic surgeon. In North America, the plastic surgeon and maxillofacial surgeon are totally separate. But in China, we're able to do both. So we don't need two different specialties to deal with it. So these are basically all the dental group is concerned: maxillofacial surgeon, anesthesiologist, pediatric dentist, orthodontist, and prosthodontist. And of course, the other disciplines include speech pathologist, because of the problem in speech, audiologist, hearing, and feeding problems, and pediatrician and otolaryngologist. This is terrible. This is so close together. As far as goes in management of the cleft palate patient is, during the infancy period, we worry about the aesthetics and function. And as far as the pre-adolescence is concerned, we worry about development of arch form. It's quite important. And the alveolar bone graft. They're so close together. When I press this automatic goes.
Touching this because
Okay.
if you touch it, it's better. Just use it one time and it just don't go. Try use it this because this is always going. Okay.
Okay, I want to do this one. Okay.
You can, yeah.
Maybe you can do this one.
Yes,
So
this one is better.
Just do this one.
it's a big one.
So can I go backwards now?
Yeah, yeah.
Okay, so I can use this just for this. So we talk about infancy, pre-adolescence. This is extremely important because it develops the arch form. And during the adolescent, we're more worried about function and aesthetics. And finally, as far as the completion of growth is concerned, we deal with the facial aesthetics through orthodontic surgery and tooth replacement wherever it's necessary. Now, as far as dentistry team is concerned, we have the pediatric dentist, especially in mixed dentition period, the orthodontist that deals with the permanent dentition, and they together with the oral maxillosurgeon deal with the orthodontic surgery. And as far as the oral and maxillofacial surgeon is concerned, they do secondary alveolar bone graft, and they correct facial skeletal deformities, augments bone and places implants. And finally, the prosthodontist, they coordinate and replace missing teeth or prosthetics. Now I'm talking about Boston Children's Hospital with Harvard University. This is basically their protocol. You phase 2 is orthodontics, surgery, and then prosthetics. This is very important. A lot of places do not do orthopedics. We find it very important as far as the development of arch form is concerned. And then phase 1 orthodontics, we deal with a mixed dentition. And this is the time where we do the expansion because there's a lot of maxillary constriction there. And then the surgical bone grafts. And finally, we do alignment as far as ortho is concerned. And then we do the orthodontic surgery and prosthetics. So this is what the maxillosurgeon does. Bone graft, correct facial skeletal deformities, and augments bone and places implants. Now, the most common oral findings with cleft lip and palate patients are concerned, majority of them have maxillary hypoplasia. So there's quite a lot of, you can see a lot of midface deficiency. And as far as mouth oral findings concerned, we have tooth anomalies, and we have bone defect, and we have fistula. And finally, there's nasal labial deformities. I don't think we need this one. This is very, very typical. You can see because of the constriction here. And this is the skeletal aspect. You can see the very pronounced constriction in the maxilla. And you see you have missing teeth. The lateral incisors are missing. And the teeth are very poorly formed, malformed. It's more in the maxilla than in the mandible. And you can see the alveolar bone defect. And the teeth are poorly formed, malformed. These are very typical. So it's very obvious in the mixed dentition phase, you can see, because this is unilateral, so you have asymmetrical maxillary constriction instead of bilateral. And you have a post-crossbite, the bite is reversed. And also as well at the back as well, you have posterior crossbite, especially after surgery. And you have dental alignment, malformed, missing, or extra teeth. You can see asymmetric maxillary constriction. Even along, it's not only along the cleft, it's even along cleft, non-cleft area, you can see pore formation. So it's not just the cleft area alone. So as far as treatment is concerned, we deal with the neonatal period where we need the orthopedic appliance and the labial palatal repair. And during the prime and mixed dentition, we do the orthodontic treatment and pharyngeal flap. And finally, in the permanent dentition, we do the comprehensive ortho treatment, orthodontic surgery, lip and nasal revision, and finally dental implant where there's missing teeth. So the pre-surgical orthopedics during the neonatal period is quite important because it brings the labial elements closer together and also improves the maxillary arch form because that's the time where it's developing very rapidly. And we also do gingival periosteoplastic to close the fistula. These are the neonatal treatment. It's sometimes you do not, where you do not do any treatment. So the pre-surgical orthopedics, you begin no sooner than 5 weeks. It will make an impression and we can appliance for them. And the removal of the same appliance and the same anesthetic. And finally, after this, 1.5 months later, we do the surgical lip repair. You get a much better result with that. And then palatal repair occurs later, 10 months. So the first, during the infancy period, we first physically alginate with custom trays and fabrication and insertion of we do with all those digital improvement, we don't have to put them under, we can just do digital. Now, this is pre-surgical orthodontic treatment with NAM. So we impression custom trays. These are the impression material. We use the alginate. And then do appliance construction. pin locations where you can do the adjustment with these pins. You do the try-in, insertion of retention pins, and load it through and activate. This is how mouth. And this is the kit after following appliance removal. You can see it's much better now as far as arch form is concerned. You can symmetry cleft here. This is at 8 months. So as far as Guangzhou is concerned, we do the impression 2 to 4 weeks, custom tree for impression, and then stand. And they do the cleft repair after 4 months. So this is the presently Guangzhou Maternal Child Center in China. So they use the digital technique. So everything can be done at one time. You don't have to visit as much, and you can easily fit in very good result. So everything is with the digital technique. You can see that they're doing it digitally. As you can see, it's much easier. You can literally design digitally as well. And you can print it through 3D, so you don't need to go through all the others. That's one of their patients. And this is the same one. This is 5 months pre-op, and this is 5 years post-op, the same kit. This is a case in Boston Children's. You can see it's relatively quite severe bilateral cleft here. You can see that. This is what they did. This is pre-op, and this is post-op. And this is the same child. You can see the result. So we just want to review it again. It's the stages of treatment. Do the neonatal period, we do the orthopedic appliances, and then we do orthodontics, and finally orthodontic surgery, including distraction. As far as children, this is again Boston Children's at Harvard. Comprehensive orthodontic records. Maxillary expansion, because of the hypoplasia, you have to do that. And then do the dental alignment with fixed appliances. And finally, functional appliance if indicated. So as far as we showed it to you already, as far as the mixed dentition, you have the posterior crossbite, anterior crossbite. And as far as the last phase during the permanent dentition, you basically involve the plastic surgeon, otolaryngologist, orthodontist, physio, and prosthodontist, and they do an interdisciplinary care. And the cleft team actually meets regularly as far as Boston and Canada is concerned. They do it every on a weekly basis, and so everybody knows what's going on with the patient. So you can see as far as orthodontic surgery, because the maxillary hypoplasia occurs in 20% of patients. Now, we're talking about alveolar bone grafting. It's relatively important because it stabilizes the maxillary segment, and it only support, and it has aesthetic appearance and also support the base of the nose. It's quite important. And it allows bone for titanium implant later on. As far as the timing of the bone graft is concerned, we usually do it prior to the canine eruption when the root is about 1/2 to 2/3 formed. So viable, the lateral incisor is present at 5 to 7 years. You can see it there. You can see we want the root to be formed approximately half. And these are the orthodontic wiring. Now you can see the canine, the eye tooth erupting in that area. It's missing the lateral incisor through the bone graft. And this one. Yeah, this is the crossbite. You can see everything is reversed. This is pre-op and this is post-op. You can see the crossbite is gone. The bite is relatively in place. They move the tooth forward. You can see this. And this is post-op. You can see the surgery that's done to correct the crossbite. And this is a patient before and after. It makes quite a big difference as far as, and also they did a little bit of the nasal area. This is the same kid. So as far as the final phase of treatment is concerned, we need a dental implant to replace any missing teeth. And you know, with this rhinoplasty, with the septal deviation, and finally, you do the final labial revision better and with the dermograft. You can see where there's missing teeth over here. They did an implant, put in a lateral incisor, so that makes it look much better. This is the same kid. Field vision is concerned. And you can see this is the case with a lot of septal defect over here. And this is the before, and this is after. The same kid on a lateral profile. I purposely mentioned this one because we started the program over in Guangzhou. People to the kids that we trained in so from didn't, so, which I think is not bad. So I wanted to show you this is not from us from North America, but a kid that was trained in China. So I'm very proud of this. So just remember the guiding principle: best facial aesthetics possible, minimize the prosthetic requirement, coordinate the treatment plan early, and enjoy interesting cases. This is a book that we wrote with the group from Harvard and in China. So Bonnie is now a prof at Harvard University now, Bonnie Padua. And Richard is orthodontist, also a prof. So these are the group that we wrote a book in China about treatment for cleft lip and palate management. And I just want to show you the statistics, how many kids we treated just in one center alone in Guangzhou. Starting off in 1999, ending in 2023. Total treatment cases is 19394. That's a relatively large group. Only time it's small is because of the COVID in 92022. That's a relatively small statistics because of the COVID involvement. Thank you for sharing.